Greetings everyone, my name is Richard Benian and I'm an oral maxillofacial surgeon. And I was asked to give a presentation to you today, so I decided to discuss odontogenic infections with you. A little bit of administrative information. This activity will be available to all members after October 1st, and 2 CDE credits will be issued upon completion of the post-CDE tests. Members registered for this conference will need to view the presentation prior to September 25th. Then you can document questions for the in-person panel discussion and question-answer sessions in Las Vegas. We invite learners to pay attention and make a note of the 2 secret codes mentioned during this activity to earn this 2 CDE credits. The first one is cavernous, C-A-V-E-R-N-O-U-S, and the second one is Ludwig, L-U-D-W-I-G. Odontogenic infections have sources from pulpal disease, periodontal disease, pericoronal infections, odontogenic cyst infections, odontogenic tumor infections, infected extraction sites, and infected maxillofacial fractures associated with teeth. Most infections are from indigenous bacteria and/or fungus. The bacteria are primarily aerobic and anaerobic gram-positive cocci and anaerobic gram-negative rods. They can cause decay and periodontal disease that then get into access to deeper spaces and tissues. Odontogenic infections are usually polymicrobial. They are rarely caused by a single species. On average, there's approximately 5 species isolated, and not unusual to find as much as 8 species. Most are mixed infections of anaerobic and aerobic species, which makes up about 50% of the infections. Aerobic species alone approximately account for 6% of odontogenic infections, and anaerobic species alone account for about 44% of infection cases. These numbers vary depending on the reference sources that you read. Aerobic bacteria, the most common type are Streptococcus malariae group and the Staphylococcus bacteria. Minor contributions are from gram-negative cocci, gram-positive rods, and gram-negative rods. The Streptococci malariae aerobic gram-positive cocci are made up of 3 members of the Streptococcus viridans group. These include the Streptococcus aeruginosus, Streptococcus intermedius, and Streptococcus constellatus. Among the anaerobic bacteria, the most common is gram-positive cocci. That includes Streptococcus and Streptococcus. The gram-negative rods, and these will include the Prevotella and Porphyromonas species, as well as Fusibacteria. Less common opportunistic organisms will include gram-negative cocci such as Veillonella, and the gram-positive rods such as Actinomyces or Lactinobacilli. There are 4 stages of odontogenic infections. The first stage is the inoculation stage, which is roughly from the onset of infection to about approximately 3 days after the infection starts. Initially, there's gram-positive cocci that invade and colonize the host. The tissues generally are soft, moderately tender on palpation, and doughy consistency with swelling. The second stage is the cellulitis stage. This is roughly from the 3rd to the 5th day after onset of the infection. This is a mixed aerobic-anaerobic species infection, and tissue is firm, red, inflamed, and very tender to palpation, and it is swollen. The abscess stage, roughly between the 5th and 7th day after infection onset, is primarily made up of anaerobic bacteria. Liquefied abscesses in the center of the swelling is usually present due to cellular debris and tender to palpation. The fourth stage is the resolution stage, which occurs after spontaneous drainage of the infection or surgical drainage. Along with this, to assist in resolution would be the host immune system and antibiotics if they're given. As can be seen, odontogenic infections are generally due to aerobic and anaerobic gram-positive cocci and anaerobic gram-negative rods. Comparison of edema, cellulitis, and abscess is noted on this chart. There's a lot of variations of the various characteristics, particularly the duration periods can be variable, and the progression also can be extremely variable. The infection process starts with the inoculation of the deep tissues. There's synthesis of hyaluronidase by Streptococci malariae group bacteria. This allows other organisms to initiate the cellulitis stage, which is made up of aerobic and anaerobic Streptococcus infection. The Streptococci create a favorable environment for anaerobes by releasing essential nutrients, lowers the pH of the tissue, and it consumes the oxygen. This allows for an anaerobic environment for the anaerobic bacteria to become predominant and causes liquefaction necrosis by collagenase, which induces the abscess. In the inoculation phase of infection, the hallmark is edema. There's minimal tenderness and perhaps a jelly-like consistency. In the cellulitis phase, it's usually acute, more painful, larger, indurated, and with diffuse borders. And it can be very aggressive. In the abscess stage, it's usually chronic in nature. It's an indication of increased host resistance. There can be pus with fluctuants, and it's generally less aggressive. However, this is not always the case. Treatment modalities of odontogenic infections include medical or surgical. However, usually both are required. Medical treatment would be to evaluate the vital signs of the patient, determine the status of the airway in severe infections, which likely will require airway protection and support. You want to evaluate the host defense of the patient. You're going to do laboratory studies, which includes a CBC with a differential, hemoglobin, hematocrit, liver function test, coagulation status, blood cultures, and cultures of any spontaneous drainage. In severe cases, you're going to treat the patient in a hospital setting. You'll administer antibiotics, preferably after cultures are obtained, especially in patients who are immunocompromised or in patients who have extensive abscess or cellulitis. You'll administer analgesics as necessary. You'll adequately hydrate the patient with IV fluids, maintain an MPO status in case the patient has to go to the OR. You'll monitor the patient frequently. You'll possibly use antiseptic mouth rinses for intraoral lesions, infections, or incision and drainage sites. You want to administer a diet high in protein content due to the catabolic state of the patient. Not all infections require antibiotics. They're indicated when swelling is extending beyond the alveolar process. There's cellulitis or abscess. There's lymphadenopathy, or if the patient has a temperature higher than 101.0 degrees Fahrenheit, you'll give it in severe pericornitis states and osteomyelitis situations. Antibiotics are not necessary in simple toothache or if the patient demands it. In minor periapical abscesses, not typically required, but this is a judgment call on the part of the practitioner. Dry sockets do not require antibiotics. Multiple dental extractions in patients who are not immunocompromised do not require antibiotics. Mild pericoronitis with minor gingival edema and pain also do not require antibiotics. However, this too is determined on the judgment of the patient or the practitioner. Also, if there's adequate drainage of an alveolar abscess, antibiotics are not typically needed. You want to determine the severity of infection, whether it's mild and or minor. Typically surgery is not required. You want to determine the infection based on a complete history, physical exam, and radiographic exam. With a complete history, you're going to get the chief complaint, time of onset of the issue or infection. You determine the course of the infection since onset, the rate of progression of the infection, the patient's symptoms, which will include pain, swelling, fever, loss of function, redness, discharge, dysphagia, dyspnea, trismus, airway obstruction. You'll note the general appearance of the patient, whether they're severely malaised or have a toxic appearance. You want to note any previous treatments for their infection. You'll note their past medical histories, past surgical history, allergies, medications, family history, and social history. In a physical exam, you'll get vital signs and do an extraoral and an intraoral exam. For your intraoral exams, you'll look for decayed teeth, periodontal disease, loose teeth, fractured teeth, purulent discharge, elevation of the floor of the mouth or tongue, deviation of the uvula, deviation of lateral posterior pharyngeal tissues, deviation of the tongue, inability to swallow, a change in phonation, and if there's trismus. Extraorally, you'll inspect the general appearance of the patient. You'll note any cardinal signs of inflammation, which will include pain, heat, redness, swelling, loss of function. You'll palpate the areas of swelling. You'll look for tracheal deviation, inability to swallow, extension, elevation of the tongue, drooling, trismus, and whether the patient is posturing their head forward. You'll evaluate for lymphadenopathy and look for draining sinuses or fistula. If the patient has any facial fractures that can be infected, you want to also note those. Radiographic exam will include periapical dental x-rays if it's possible, assuming the patient does not have severe trismus, limiting your access to getting them. A orthopanograph or panograph x-ray is a very good preliminary x-ray to get a good visualization of the teeth and a maxilla and a mandible. It's particularly good for patients with trismus. Oftentimes, a medical grade CT is going to be required. This is good for looking at both the hard and soft tissues at the same time, and also the extent of the infections and location. It's best done with contrast if it's not contraindicated. You're going to establish assessment of the patient's infection, which is whether they're in the incubation state, the cellulitis stage, or the abscess stage. You document the severity as low, moderate, or high. You want to consider the patient's defense systems. You want to look at their immune system for suppressing diseases such as HIV or AIDS, lymphoma, leukemias, other malignancies that might be present, or congenital or acquired immunological diseases. We also want to note if the patient is immunosuppressed with chemotherapy or corticosteroids, and if they're on medications for organ transplants. Also, you want to note any metabolic diseases, such as poorly controlled diabetes, alcoholism, whether the patient's malnourished, or if they're in end-stage renal disease. When to refer the patient to the oral maxillofacial surgeon or head and neck surgeon is when the patient has difficulty breathing, swallowing, if they're dehydrated, if they have moderate to severe trismus, if they have swelling beyond the alveolar process, their temperature is greater than or equal to 101.0, if they're in need of general anesthesia, if they have severe malaise or have a toxic appearance, if they have a compromised host defense, if they have prior treatments that have failed, and if they need the hospital setting to manage other medical issues. Indications for hospital admission would be a temperature greater than 101.0. If the patient's dehydrated. You want to note if there's any threat to their airway and any vital anatomical structures, and if so, this too would require hospital administration. Infections in anatomical spaces are also a good indication for admission to the hospital. Need for general anesthesia, need for medical management of systemic disease, if you have to establish a secure airway, and if you need to do incision and drainage of multiple space abscesses, or if the infection is rapidly progressing. All these would be indications for admission to the hospital. Surgical treatment will include endodontic therapy, intraoral incision and drainage, extraoral incision and drainage, and/or neck incision and drainage. The goal of the treatment is to remove the source of infection and provide path for drainage. Cultures and sensitivity tests should be done prior to administration of antibiotics, but if they're not able to be done, then they can be done after the antibiotics have been given. You want to use a large bore needle for aspiration and purulent discharge. You also want to administer soft tissue or hard tissue specimens to the microbiology lab. Indications for culture and sensitivity tests would be a compromised host of the patient, recurrent infections not responsive past 48 hours, if the patient's had multiple antibiotic therapy, rapidly progressing infection, or infection spreading beyond the alveolar process, or if they have a postoperative infection. Factors that are being considered for the use of antibiotics. You want to use antibiotics specific as soon as possible based on a culture and sensitivity test. Again, it's best to get your culture and sensitivity studies prior to the start of antibiotics if possible. Of course, a good surgical treatment of the infection is primary, otherwise the antibiotics would not have much of an effect. You want to use combination of antibiotics only when necessary. You want to use the narrowest spectrum empiric antibiotic effective against the most likely pathogens. You want to use the least toxic antibiotic. Of course, you want to minimize the duration of the antibiotic therapy and use the least expensive appropriate antibiotic. Reasons to change your antibiotic would be allergic reaction or a toxic reaction or intolerance by the patient. Or if your culture and sensitivity studies show that the bacteria isolated is or are resistant to the antibiotic that you chose empirically. If there's no improvement after 48 to 72 hours on the same antibiotic, it may be a reason to consider changing it. This is despite removal of the source and adequate drainage of the infection. You want to frequently evaluate the patient, so you want to closely monitor their response to treatment, check for complications from surgery or antibiotics. You want to monitor for increased pain, swelling, trismus, temperature, and monitor their drains. You monitor their vital signs and general appearance, and you want to monitor for recurrent infection. Of course, you want to continuously monitor the laboratory test. Causes of treatment failure would be inadequate surgery, a foreign body in the infection site, such as a tooth fragment, necrotic bone, dental restorative materials, or food debris. Antibiotics related issues would be a non-compliant patient, insufficient antibiotic dose, the incorrect antibiotic, wrong identification of the bacteria, an antibiotic not reaching the site of infection, and of course if the host defense of the patient is depressed, this may cause failure of treatment. Classification of odontogenic infections. We'll be talking about these 18 different infections in the head and neck region. The first will be the periapical abscess, where the infection transverses from dental decay into the pulp chamber, down the root canal into the periapical region. These dental x-rays show a periapical radiolucency, indication of a periapical abscess or granulation tissue secondary to dental decay. This shows a periapical abscess with a fistula through the buccal cortex, which causes swelling under the periosteum and the associated gingiva. This is a periapical infection or granulation tissue from a tooth that has dental decay in it. A palatal abscess is very similarly caused like a periapical abscess is, where the infection will protrude through the palatal cortex under the periosteum and causes swelling in the palatal tissue. This is a classic clinical expression of a palatal abscess. Incision for this would be in this region here, where it could be dependent drainage. Odontogenic infections can penetrate into the maxillary sinus due to the close proximity of the roots to the floor of the sinus. This is a periapical x-ray showing a periapical abscess with an oral antral communication and an air fluid level inside the maxillary sinus. This is another example of periodontal abscess with an oral antral communication leading to opacification in the left maxillary sinus completely and a partial opacification in the right maxillary sinus. The next space infection would be the temporal space. It's between the temporal fascia and the temporal bone and temporalis muscle. It inferiorly communicates with the infratemporal space, which would be right in this area here. So the superficial temporal space is located here, deep temporal space here, and the infratemporal space more medial to that. Mesenteric space would be here, and the pterygomandibular space would be located here. This is a clinical example of temporal region swelling and abscess. You see the temporal swelling here as well as here. These temporal space abscesses are typically above the zygomatic arch, and drainage either can be done from an intraoral approach or from an extraoral incision in this location. An infratemporal space abscess would be in this region here. It's usually caused from maxillary molars. The infection may ascend to the cavernous sinus, to the orbit, temporal fossa, and the pterygopalatine fossa. This is a bilateral infratemporal space abscess in this patient. This is extremely rare. And I mean by that is it's rare to have bilateral identical space abscesses. Typically, it would occur on a unilateral basis. The next infection would be the cavernous sinus infection. This is usually caused from infections on the face or the oral cavity, where it can get access to the facial vein and angular vein, and by anastomosis with the superior and inferior ophthalmic vein and the infraorbital vein, as well as the deep facial vein, can transfer posteriorly to the cavernous sinus. From the deep facial vein, they can get into the pterygoid plexus, which is here, and then through the emissary veins get access to the cavernous sinus. So there are several routes to the cavernous sinus from the facial veins. This shows the internal external jugular vein. A branch off the external jugular vein will be the facial vein, which then communicates as part of the angular vein, which can go to the infraorbital, the inferior ophthalmic, and even the superior ophthalmic veins. All can lead to the pterygoid plexus via communicating veins. Cavernous sinus infection signs and symptoms will be periorbital edema, headache, photophobia, proctosis, which is bulging of the eye. You have ptosis, which is drooling or drooping of the upper eyelid. You have chemosis, which is swelling of the conjunctiva. Cranial nerve palsies of the 3rd, 4th, 5th, and 6th cranial nerves can occur. You can have sensory deficit of the ophthalmic and maxillary branches of the 5th cranial nerve. Periorbital sensory loss can occur. There can be impaired corneal reflex. There also could be papilledema, retinal hemorrhage, decreased visual acuity, and blindness may occur from venous congestion in the retina. Patient will typically have fever, tachycardia. They could be septic. They could have nuntial rigidity of the back of the neck and the head. There could be mydriasis, which is a dilated pupil or a sluggish pupil. The infection can spread to the contralateral cavernous sinus. There possibly could be seizures, and there's severe frontal and periorbital pain. Ocular manifestations can include ptosis, chemosis, proctosis, sensory loss or periorbital pain, corneal ulcers, lateral rectus palsy, complete ophthalmoplegia, decreased visual acuity, or blindness. These are all signs and symptoms that dentists should be acutely aware of and be able to evaluate for in case referral needs to be done to an oromaxillofacial surgeon or a head and neck surgeon. This is the clinical features of a cavernous sinus thrombosis. You can see the bilateral periorbital edema, erythema. This is chemosis and ecchymosis. Cavernous sinus can also cause obstruction of the internal carotid arteries. In this case, it's a bilateral event where the IV contrast is not getting past this point here and here. Most septic cavernous sinus thrombosis cases result from spread of infection from the nose, sphenoidal, or ethmoidal sinuses. And in 10% of the cases, it's from dental infections. Predominantly, Staphylococcus aureus is the most commonly found culprit for these infections, as well as Streptococcus. Gram-negative rods and anaerobes may also lead to cavernous sinus thrombosis. However, fungi are rarely a cause, but they can be. The complications from cavernous sinus thrombosis can include intracranial extension of the infection, which may result in meningitis, encephalitis, brain abscess, pituitary gland infection, and epidural or subdural empyemas. The cortical veins can be thrombosed and result in hemorrhagic infarct. Extension of the thrombus can occur to the other sinuses within the brain. Treatment will include broad-spectrum IV antibiotics until a definite pathogen is found. Usually it will require 3 to 4 weeks of antibiotic therapy with nafcillin, cefotaximine, or metronidazole, or a combination thereof, as well as vancomycin if the patient has MRSA. Anticoagulation therapy as well as steroid use is controversial in these cases. The surgery is an option as well. The prognosis of cavernous sinus thrombosis before the onset of antibiotics is about 80 to 100%. Death was usually due to sepsis or central nervous system infection. Today, with the use of antibiotics, the mortality rate is about 20% or less. The morbidity was high before antibiotic use, which is about 70% if the patient survived. It's down to about 22% now. The next space infection to talk about here would be the submandibular space, or the space below the mylohyoid muscle. For an example, an odontogenic infection can penetrate through the lingual cortex and under the mylohyoid muscle, inducing a submandibular space abscess. This is a classic clinical expression of a submandibular space abscess where you have a dome of erythema, edema, the skin tissue looks shiny, and the surrounding tissue looks fairly normal. If this was to remain, either the infection will get larger, and eventually this tissue will weaken, and perhaps it would spontaneously rupture and drain itself. Next space to talk about is the sublingual space, which is above the mylohyoid muscle, and usually infections in this area will cause an elevation of the floor of the mouth. The infection will transverse from the periapical area through the lingual cortex above the mylohyoid muscle and under the tongue. You can also get a submental space abscess from particularly the mandibular anterior teeth, where periapical abscess can drain through the buccal cortex and under the mentalis muscle, which then can induce the submental space infection. This is a clinical presentation of this patient with a submental space abscess. You can see the hint of erythema in this region here, and the surrounding tissue actually looks fairly normal. And of course, there's no swelling in the submandibular space. The next infection to talk about is Ludwig's angina, which was identified by Wilhelm Friedrich von Ludwig. The definition is a bilateral submandibular, sublingual, and a submental space infection. The important point here is that it has to be bilateral. If it's not, then it's not a true Ludwig's angina or Ludwig's infection. Ludwig's angina is an aggressive, rapidly spreading cellulitis without lymphadenopathy and low frequency of abscess formation, with high potential for airway obstruction. The infection requires careful monitoring and rapid intervention for prevention of asphyxia and aspiration. This is a clinical presentation of a Ludwig's infection where there is bilateral submandibular infection. There's submental swelling. The tongue is protruded superiorly as well as anteriorly, indicating the floor of the mouth is also involved in infection. In this case, you can see the cellulitis and edema, and this patient also has a fluid accumulation of pus. This is also showing the cellulitis and edema in this axial CT with two loculations of purulence here and here. The sagittal view shows loculation of abscess here and here, and submandibular, submental edema. Common signs and symptoms of Ludwig's angina would be fever, malaise, weakness, fatigue, bilateral neck swelling, odontophagia, trismus, pain when the tongue is moving, otalgia, stridor, drooling, dyspnea, tachypnea. It could be cyanosis, dysphonia, and dehydration. Ludwig's angina is commonly a polymicrobial infection and typically is anaerobic. Organisms most often isolated are Streptococcus viridans, Staphylococcus aureus, and Streptococcus epidermidis. Other commonly involved bacteria include Enterococcus species, E. coli, Fusobacterium, Klebsiella pneumoniae, Actinomyces species, Bacteroides, and Peptostreptococcus. Treatment of Ludwig's angina would be giving supplemental oxygen. We want to manage the patient's airway. Typically, this would be involving a nasal intubation with flexible intubating and an endoscope. Many times, the patient will require a cricothyrotomy or a tracheotomy. IV hydration is very helpful, as well as IV antibiotics. On an empiric basis, you want to give Unicin, which is ampicillin and sublactam, or ceftriaxone or clindamycin. In an immunocompromised patient, you want to give cefepime, imipenem, meropenem, or piperacillin with tazobactam. With MRSA infected patients, vancomycin or linaclotide will be added. You want to support the patient nutrition. You're going to do incision drainage of all abscesses or cellulitic areas. And you're going to admit the patient to an IV or intensive care unit. This is a clinical presentation of a patient who has had bilateral submandibular space incision drainage, submental space incision drainage. As you know, there's also a tracheostomy tube here. It's possible the patient could have intraoral drains also. Next infection space would be the medial pterygoid, otherwise known as the pterygomandibular space, which is located right in this area here. Between the medial pterygoid muscle, the lateral pterygoid muscle, and the medial side of the rings. Infections in these areas are typically due to mandibular third molars, pericoronitis, or from contaminated local anesthetic needles. The clinical features include abscess of an extraoral swelling, so you need to look intraorally. However, with trismus, you may have to do your exam under general anesthesia. They will have difficulty swallowing, anterior bulging of half of the soft palate and tonsillar pillar with deviation of the uvula to the unaffected side is common. Spread of these infections can go superiorly to the infratemporal space, medial to the lateral pharyngeal space, and also to the submandibular space. Next space would be the masticator space, which is made up of 4 separate spaces. These include the mastoteric, otherwise known as the submastoteric space, the pterygomandibular space, the 2 spaces of the temporal space, which includes the superficial and deep temporal spaces, and the infratemporal space. Be aware that the masseteric space is different from the masticator space. This diagram depicts the masticator space and the associated spaces within it. That includes the superficial temporal space, the masticator space, and the pterygomandibular space, the infratemporal, and the deep temporal spaces. This MRI axial and coronal views outlines in white the masticator space, as well as here and here. This is a temporalis muscle, the ramus, and the masseter muscle, medial pterygoid, lateral pterygoid. Next space to talk about is the buccal space, and it's between the buccinator muscle and the skin overlying it. This is a clinical picture of a buccal space infection. The patient has trismus, and there's definite swelling buccally. This patient may also have a submandibular space abscess, but it's somewhat difficult to tell. With the trismus, it's also going to be difficult to look at the posterior pharynx to evaluate for any other infections. So this may have to be done under general anesthesia. A canine space infection is in the region between the anterior surface of the maxilla and the overlying levator muscles of the upper lip, which would be in this area here. The infection spreads to the alar region on this side in this patient and into the infraorbital regions here, causing erythema and edema. Maxillary canines are first premolar infections, and sometimes mesobuccal roots of the first molars are the culprits. It can lead to orbital cellulitis and even a cavernous sinus thrombosis, as you can imagine. The next space infection is the pharyngeal space, which is located in this region medial to the ramus of the mandible. This diagrams the pharyngeal space here. Within it is the carotid space. It's lateral to the retropharyngeal, the danger space, and the prevertebral space. The pharyngeal space extends from the base of the skull down to the hyoid bone. Medially, the pharyngeal wall is here. Lateral being the parotid gland. The pharyngeal abscess clinically will express itself as a swelling in the lateral pharynx, and it can cause enough swelling where the uvula can be deviated to the opposite side. This axial CT shows a loculation of the abscess medial to the ramus of the mandible. The lateral pharyngeal wall can receive infections from the pterygomandibular space, the submandibular space, the peritonsillar space, and the sublingual space. And it can go from the lateral pharyngeal space to the cavernous sinus, causing a thrombosis. It can lead to meningitis and to brain abscesses. It can go to the retropharyngeal space, the carotid space, the danger space, and the prevertebral space, which then can lead to mediastinitis. This picture shows the pharyngeal space in purple, the masticator space in light pink, the retropharyngeal space in yellow, the danger space in orange here. The pharyngeal space communicates with the retropharyngeal region, submandibular, sublingual, and the masticator space. The pharyngeal space is divided anterior and posteriorly by the styloid process. And the classic clinical expression is swelling in the lateral pharyngeal tissues. If the anterior compartment is involved, you'll get prolapse of the tonsil and tonsil fossa. You'll have trismus due to spasm in the medial pterygoid muscle. The external swelling can be in the area of the angle of the mandible, and it is associated with marked odontophagia. If the posterior compartment is involved, there will be a bulge in the pharynx behind the posterior pillar. The paralysis of the 9th, 10th, and 11th, and 12th cranial nerves can occur along with the sympathetic chain involvement. There also can be swelling of the parotid region. Again, there can be fever, odontophagia, a sore throat, torticollis, and signs of toxemia are common in both compartments. Complications from a pharyngeal abscess can be due to spread from the skull base to cause meningitis, spread to the carotid sheath, which can induce thrombosis of the internal jugular vein and rupture of the carotid artery. You can get extension to the mediastinum, which causes mediastinitis, extension to the larynx, which can induce laryngeal edema. It can rupture into the pharynx, cause aspiration and bronchopneumonia. Next space to talk about will be retropharyngeal space infections. It is the connective tissue space between the buccopharyngeal fascia and the prevertebral fascia. These two fascias are attached to each other by a medium raphe. It extends from the skull base to the posterior mediastinum. These infections are more common in children, and it's due to lymphadenitis secondary to upper respiratory infections. In adults, it's likely to be secondary to TB of the cervical spine or trauma or instrumentation. Extension of infections from adjoining deep neck spaces can cause these infections too. They can extend to the mediastinum, to the danger space, and to the peripharyngeal space. The clinical features of a retropharyngeal infection are stiff neck, dysphonia, dysphagia, a unilateral bulging of the posterior pharyngeal wall, whereas for a prevertebral abscess, it causes typically a midline bulge in the posterior pharynx. So that's how you can differentiate between the two. Complications from a retropharyngeal infection can be airway obstruction, aspiration pneumonia, acute mediastinitis, and it can spread to the danger space. This is a retropharyngeal abscess. It's located here. Again, axial and sagittal CT scans of retropharyngeal abscess here as well as here. Clinical picture of lateral displacement of the pharyngeal tissues to the opposite side is the next space to talk about is a danger space. It lies between the alar fascia anteriorly and the prevertebral fascia posteriorly. It extends from the base of the skull to the diaphragm, and it is continuous with the posterior mediastinum. Infections of it present nearly the same as the retropharyngeal space infection. It can cause from extension of retropharyngeal, prevertebral, or peripharyngeal space infections. There's no midline raphe like there is with a retropharyngeal space. And infections can spread from the neck to the posterior mediastinum easily. The reason for the spread is that there's no medium raphe as well as There's only loose areolar tissue within the space, so he has an easy access to spread. In the thoracic region, it is continuous with the posterior mediastinum, which contains the vena cava, the aorta, thoracic duct, trachea, and esophagus. Infections in a danger space can erode to compress the major vessels, the lower airway, and the upper digestive tract. Next space to talk about would be the perivertebral space. Is formed by the deep cervical fascia. It extends from the skull base down to the coccyx. The fascia attaches to the transverse process of the cervical vertebrae, dividing this space into the anterior, otherwise known as the prevertebral part compartment, and the posterior perispinal part compartment. In the prevertebral compartment, you'll have the vertebral bodies, spinal cord, vertebral arteries, the phrenic nerve, and prevertebral and scaling muscles. In the perispinal portion, you'll have the posterior vertebral elements and the paraspinous muscles. This shows the paraspinal component of the perivertebral space here as well as here. And then in the prevertebral, perivertebral space located anterior. This too shows the perivertebral spaces, the prevertebral part and the paraspinal part. This shows imaging of prevertebral abscess here and here. Next space to talk about would be the carotid space, which is located within the pharyngeal space. It is covered by the superficial, middle, and deep layers of the deep cervical fascia, as outlined in purple, yellow, and pink, or light blue. Here again, the carotid space is within the parapharyngeal space. The spaces that traverse the full length of the neck would include the carotid space, the retropharyngeal space, the perivertebral space, and the danger space. Whereas the suprahyoid neck spaces will include the pharyngeal, carotid, pharyngeal mucosal space, masticator space, and the buccal space. The carotid space, again made up of the three portions of the deep cervical fascia, includes the jugular vein, the carotid artery, cranial nerves 9, 10, 11, and 12, as well as the sympathetic trunk. The carotid space is also known as the Lincoln's Highway of the neck. This is to be analogous with the Lincoln Highway that traverses the full width of the United States, being similar to the carotid space traversing the full length of the neck. It is a tubular space surrounded by the carotid sheath, which contains the carotid artery, the internal jugular vein, cranial nerves 9 through 12, and the sympathetic chain. Again, it's made up of the superficial, middle, and deep layers of the deep cervical fascia. It extends from the jugular foramen and the skull base to the aortic arch at the thoracic inlet, and is divided into the suprahyoid and infrahyoid region. The suprahyoid region or space of the carotid space would include the internal carotid artery, the internal jugular vein, cranial nerves 9 through 12, along with the sympathetic plexus and various lymph nodes. The infrahyoid space would include the cranial nerve 9, the common carotid artery, the internal jugular vein, and also lymph nodes. The carotid space swelling would typically occur in the lateral neck, just anterior to the sternocleidomastoid muscle. Next space will be the parotid space, which is adjacent to the retropharyngeal and pterygomandibular space. Typically, you don't get a primary odontogenic infection of these glands or space. Usually, will come from adjacent spaces eroding into the parotid space. So the odontogenic infections can spread to it via the peripharyngeal space due to the incomplete encirclement of the superior medial surface of the parotid gland and from the submandibular space or submasseteric space. This is a clinical presentation of a parotid space abscess. In the preauricular area, you can see the swelling and the erythema. The pattern of odontogenic infection spread usually would be like from a periapical infection to the canine or buccal space. It can go to submandibular, sublingual, submental space, and they can travel in between each other. From submandibular, it can go to the masticator space or the temporal space, or from there it can go to the pharyngeal. Pharyngeal can lead to the masticator, the temporal, the parotid, the carotid, the retropharyngeal spaces. From the retropharyngeal can go to the danger space and then to the prevertebral area. Also, the peripharyngeal can involve the carotid space as well as the parotid space. So a little bit about antibiotics next. The most commonly used antibiotics in dentistry would be the beta-lactamase antibiotics, nitroimidazole, macrolides, lincosamide antibiotic, fluoroquinolones, and tetracycline. Penicillin would fall under the beta-lactamase antibiotics, as well as cephalosporins. Metronidazole would be an example of a nitroimidazole antibiotic. Macrolides would be erythromycin, clarithromycin, and azithromycin. The lincosamide antibiotic would be clindamycin, and Cipro and moxifloxacin can be or are examples of fluoroquinolones, and tetracycline stands alone as its own. At the University of Michigan, for an example, in suppurative pyrogenic orofacial odontogenic infections, such as these listed here, with these particular bacteria, these antibiotics would be typically used on an empiric basis. This is Unison, which is ampicillin and sublactone. You can use cefazolin or metronidazole, or you can also use levofloxacin and metronidazole. The duration is typically in the presence of a surgical control of the infection, be about 5 days post-drainage. In the absence of surgical control, the duration is dependent on the clinical or radiographic improvement, a minimum 7 days and at least 3 days of clinical improvement. Ludwig's angina requires about 3 weeks of antibiotics, and in all cases, the most important element is surgical drainage and removal of necrotic tissues. So for severely immunocompromised patients, or patients who have severe sepsis and or septic shock, or patients who have had in-hospital surgical procedures in the past 90 days, you can suspect these types of bacteria. You'll give these types of antibiotics. These are more aggressive, broader spectrum antibiotics. You'll give the antibiotics again for a minimum of about 7 days and at least 3 days of clinical improvement. Ludwig's angina, again, would be about a 3-week course of antibiotics. Again, the most important consideration is complete surgical drainage and removal of necrotic tissues. For osteomyelitis, which predominantly occurs in the mandible, you're going to continue the antibiotics pending microbiology data and duration to be determined based on clinical improvement from serial evaluation typically over 6 weeks' time. You also want to consider not only anaerobic and aerobic bacteria, but fungus, as well as actinomyces. The therapeutic dose for children are listed here. We also give maximum dosages. First choice would be amoxicillin. If that fails, you want to give amoxicillin with clavulanic acid. Starting to avoid using clindamycin due to C. difficile infections. Other options would be cephalexin and metronidazole. For antibacterial or antimicrobial prophylaxis treatment, the oral routes typically would give amoxicillin. If you're not able to take oral medications, you could give IM or IV antibiotics. You could also give alternatives such as cephalexin, azithromycin, clarithromycin, doxycycline for patients who are allergic to oral penicillin or ampicillin, or if they can't take oral medications, they can take IV forms of ceftriaxone and ceftriaxone in these dosages here. Again, we want to try to avoid clindamycin as much as possible due to C. difficile risk. We want to give pre-med antibiotics for patients who have prosthetic cardiac valves or materials, that have previous or relapse or recurrent infection, endocarditis, they have congenital heart disease, patients who have heart transplants. You don't have to give dental pre-med antibiotics typically for patients with these situations, but in my opinion, it is a judgment call. I would not give it for defibrillators or pacemakers, but I would consider giving it for patients with CNS ventricular atrial shunts. It's not necessary to give them for vena cava filters. Perhaps a shunt, AV shunt for hemodialysis, I would consider giving it to the patient. Not only because of that, but many times these patients have a decreased immune status. AP or antibiotic prophylaxis is suggested if there's significant manipulation of gingival tissues or the periapical region of teeth, or perforation of the oral mucosa is necessary. For minor procedures such as giving local anesthetics in a non-infected tissue, taking x-rays, placement of prostheses or orthodontic appliances or removing them, it's not necessary to give pre-med antibiotics. Also, patients who are shedding primary teeth, it's not necessary to give the antibiotics, nor is it necessary for bleeding from trauma to their lip or oral mucosa. American Heart Association suggests that for at-risk patients requiring repeated dental procedures likely to result in bacteremia, to either give an alternative antibiotic each time, or there should be intervals of at least 4 weeks between treatment sessions. The antibiotics may be given up to 2 hours after a dental procedure if they were not given prior to administration, or not prior to dental procedures. In patients who are receiving parenteral antimicrobial therapy for infection, endocarditis, or other infections and require a dental procedure, they should stay on the parenteral antibiotics throughout the dental procedure. Also, in patients who are receiving a short course, approximately 7 days to 10 days of oral antibiotic therapy before a dental procedure, it's preferable to select a different class of recommended antibiotics. For the pregnant patient, it's okay to give category A and B antibiotics as listed here. You want to avoid C, D, and X. And you want to avoid particularly like tetracycline for obvious reasons. Clarithromycin can cause increased risk of miscarriage. And in rats, chondrotoxic effects can occur both with oxyfloxacin and ciprofloxacin. However, in humans, I don't believe they have any evaluation regarding that. For prosthetic joints, it's not necessary typically to give antibiotics. However, this is a judgment call on part of the practitioner. It's recommended that you consult with the orthopedic surgeon to decide whether antibiotics should be given or not. If they say that the patient should have it, you can ask for the recommendation of the type they want. However, in many cases, these would be a cephalosporin, and you should document the antibiotic recommended by the orthopedic surgeon in the patient's chart for documentation. So, if it hurts when you touch it, the obvious thing is don't touch it. And I want to thank you for your attention. I appreciate having the opportunity to talk to everyone. Thank you very much.